more but the more biased methods. On the top left hand side, you see pill counts or questionnaires that are mostly retrospective, so asking people, did you take your medication the past week or the past time? Pill counts that are also retrospective, so asking people to bring their medication and packaging and counting how many are left over. And obviously the problem with that is easily biased. People fill in the questionnaire with let's say socially wanted answers. They use they omit the fact that they skipped dosages, and they do the same with pill counts. It's quite easy to throw away some of the tablets that you did not take, and then bring in an empty bottle and say, yes, I took all my medication. And even if it is not biased, you only have aggregate data. So you only know if people bring in their packaging and you see that they only took half of the dosages. You only know that somewhere in the past time they forgot or they did not take medication, but you don't know when. If you have a patient diary, either on paper or in an electronic form, you have more continuous assessment. So that's on the top right of the table. A patient diary gives you continuous measures over time, every day or multiple times per day. You can check whether patient reports taking their medication. But still, it is biased because people fill in their diaries with false entries, or they forget to fill in the diary, and then you still don't know whether they took the medication or not. So more reliable methods are, for instance, therapeutic drug monitoring, so plasma levels, which you know that people have the medication and ingested the medication. Pharmacy refill data, where you know that they picked up the medication at the pharmacy, but still you don't know whether. You only have aggregate data. You don't know when they missed dosages. So if people come late to the pharmacy to pick up their refill, you know that they obviously missed some of their dosages, but you don't know when they did that. If they come in and have their plasma levels checked, you can only see the plasma level for the last couple of days, sometimes hours, depending on the half-life of the medication, and you don't know whether they took the medication the weeks or months before that. And on the bottom right side, you have the medication event monitoring system, so the electronic systems, which are more or less unbiased and at least have rich sampling. They measure every time a package is opened and a dosage is taken out. And obviously you don't yet know whether people actually took the medication. You only know that they took it out of the packaging, and you know that they missed dosages if they did not open the package. So there is problems with many of these ways of measuring adherence. And on the next slide, if you can show that, you see a couple of those problems that I already mentioned. If it is easy to censor evidence that dosages are omitted, forgotten, or intentionally not taken, then people will do so. So then people will use that possibility. So, looking at tablet counts, people can inflate adherence by dumping their pills before they have them counted. Diary entries are falsified. People do not recall whether they took their medication or not, or tell the doctor what they want to hear. plasma levels are easily taken care of. If you, in most cases, if you take 1 or 2 dosages just before your blood sample is taken, your plasma level is okay, and it seems as if you've taken your drug.
Hope.
Yeah.
There's an interesting philosophical question from Camilla.
I can see it. Yeah, I always wonder why we as healthcare providers assume that patients should be interested in cheat us about their medication compliance. I think most patients are very interested in getting the best out of the medication. Yes, that's true. I think you're absolutely right. And I always have I don't like to call it cheating, so because that seems as if they do it on purpose. But I do think that if it is easy to not tell about missing dosages, then it will happen. Either whether it's on purpose or not, it will happen because well, one of the things, if people tend to forget to take their medication, it is most likely that they are also less accurate in filling out questionnaires, etc. I think one of the biggest or the nice or surprising maybe examples is one of the studies that a long time ago Marcel himself did, where we gave people these electronic pill bottles that measured opening of the bottle, and then we gave them to patients who took diuretics, and we gave them for 2 or 3 months to record their medication intake. And then one of the problems is that people did not return the bottle, and they lost the pill bottle, or they never showed up again. And we believe that those were the patients that were most interesting to us, because those were the ones that are very likely to have been non-adherent. So it is not so much that patients cheat, but it is very hard to collect data on this, and if it is easy to censor that evidence, to not show that evidence, then it will happen. Camilla, does that answer your question?
I guess it's not a question. I just don't agree on that. Yeah, I think we often as healthcare professionals look down on the patients as we have the right way to do things, and if the patient don't follow that,
Absolutely.
if they are doing it wrong, and then I actually don't agree on the term of adherence. Then we're more talking about compliance, which are the old-fashioned way of the doctor being the guard and the patient that has to obey whatever is said. So I just think that we have to move a little bit away from that and see it as a cooperation between the healthcare professionals and the patient. And we also have a responsibility to try to understand, why aren't you not taking your medication as we thought that we agreed on? And
Absolutely.
Maybe that's because the medication plan isn't fitting your life well. And then we should make another plan instead of just saying that you are non-adherent or non-compliant. Well, we have to figure it out.
May I also say something? Because this is of course has to do with the way you communicate about this. And I don't know whether I'm the only person in the room, but for example, when I'm going to the physiotherapist because I have pain in my back, and I get all some kind of exercises that take me approximately half an hour a day, and which are very boring, then I don't manage to do all these exercises. So then I go back to the physiotherapist, and then I say, okay, well, I did my exercise a little bit, but not always, and it will depend on how the physiotherapist reacts on this. When he says, okay, I understand because it's very complicated, and I also find it difficult to do this exercise, I always also have to do that, then it's different than when the physiotherapist will say, okay, you really have to do your exercises, because then next time I just say, okay, I'm doing my exercises.
Yeah, that's actually kind of my point, that we have to be better to communicate about it and take that responsibility. It often depends on how you ask, and a questionnaire could be pretty offensive in did you do it right or wrong?
Yeah.
Yes, and I think that I will also get back on that, because I will talk about what interventions work and what don't. But please remember, these are ways of measuring adherence, and they are not all meant to be used in a let's say therapeutic sense, or in a healthcare provider patient situation. Some of these are also used in clinical trials, etc., where you simply, for all kinds of reasons, want to know whether people took their medication or not, and simply try to measure it. And I think the takeaway point from this especially is that that is very hard to do, and it will, most of these ways of measuring adherence will give you some type of biased outcome. And I totally agree with your point that communication with the patient and tailoring interventions or ways of improving adherence to the patient is key, and I think we will get to that. Okay, and just to go a little bit further on ways of measuring adherence, pharmacy refill data are often used to measure adherence. So by looking at whether people picked up their medication, their repeat prescriptions, and then from that figuring out whether there are gaps in the periods of medication use, or at least gaps in getting their refill prescription on time. So here are 4 examples, and I show these to show you that it is quite hard to then measure adherence from that, and that there are different ways of different types of adherence. These are all situations in which you could say adherence is 80%. So 80% of the time a patient had medication at home, but there are obviously different types of adherence going on here. So the first one on the top left, the patient came a little bit late when they started using the medication, but then was on time and had it available all of the time. So started late, but from that moment on, actually was 100% adherent if you look at the pharmacy records. In the top right example, you see that somebody started on time, but then had a gap, did not pick up the medication on time, and then picked it up on time again. So there was a gap in use somewhere in the first period. The patient did not have enough medication at home, so we assume that the patient did not take the medication. In the bottom left, you see gaps every time a patient picked up the medication. Maybe the dosage was changed with or without knowledge of the prescriber. That can happen. Or the patient, him or herself, thought of taking less of the prescribed medication and thus picking up a little bit late. And the final one, bottom right, you see that the patient picked up the medication, was a little bit early every time, and then at one moment had a gap. But that could be that there was stockpiling of medication, so that the patient was early every time and then had a stockpile of the medication at home, and then thought, okay, I don't need it at the moment, I will wait a little bit and then pick it up. So actually there was no non-adherence. So also a more objective measure, as pharmacy records sometimes are seen, or more unbiased measure, will get you into trouble if you want to look at non-adherence, because it is aggregate data. So on the next slide, you see again some of the electronic drug monitoring devices. There's all kinds of them, pill bottles, blister packaging that measures and records every time a drug, a pill or a tablet is taken out, and these nowadays communicate wirelessly often, and you can collect the data. And on the next slide, you see an example of that. This is a patient who had a 2 times a day dosing schedule. This was a perfect patient, took the morning dosage every day at exactly the same time, and the evening dose at exactly the same time, almost a perfect 12-hour interval between the doses. This is a laboratory perfect patient. But the next one you see is also quite regular, but apparently sleeps in the weekends, because every weekend on Saturday and Sunday the morning dosage is taking much later, and then you see differences there. And then the last example, well, this is a patient who starts out okay, again 2 times a day dosing schedule. All the gray lines are missed dosages, and you see that, well, the mornings are okay for quite some times. The evening dosage is missed, and that's being missed more and more often. And then at some time during therapy, lots of dosages are being missed, and there's a drug holiday. There's a moment where there's a couple of weeks of non-drug taking, and then it worsens. This, if you measure it in this way, provides you with a talking point with the patient. If you go through this together with the patient, then you can figure out what goes wrong and use this as a starting point in your conversation, and try to figure out, well, do you forget to take your medication? Can we help you with that? Can we link it to daily activities, brushing your teeth or whatever daily schedule you have? Or is it that you don't want to take the medication? Do we need to talk about that, why that is, etc.? So it is a starting point. You don't want to use measurements like this only as a way of measuring and then saying to the patient, you didn't do it right, make sure that you take your medication, because that won't help. I will come to some of the questions in the chat after this slide, because this is the final electronic measuring device, and this goes one step further, because these are tablets with a sensor in them, and people then have a patch on their belly that measures whether the tablets are actually swallowed. So this one doesn't measure whether you take the tablet out of the bottle, but whether you took the actual dosage and swallowed it, and it goes into your system. So this is one step further. These are being used mostly in clinical trials, where it is important to know whether people took their medication or not. But there are plans, and this one is on the market already, to also use them in daily clinical practice. And with electronics becoming more and more smaller and cheaper, this is something that we will probably see more of in the future, which will give you all kinds of interesting ethical questions. And I think there are some in the chat. Do patients sign consent form previously? Yes, obviously, all of these measurements, especially these electronic measures, you use only in concordance with the patient. So you talk to the patient and ask them, are you having trouble taking your medication? Do you think it's okay to measure it for some time? And then we can look at it together, and we can see whether we can find if there's something wrong. If you don't manage to take your medication on the right time, then we can figure out whether we can help you with that and change that. And we we've done a lot of studies with these kinds of electronic monitoring systems, and most patients don't have any problem with that, and they don't have a problem with privacy issues, etc. On the contrary, they find it very interesting, and you almost always see that every patient that you give an electronic pill bottle, that in the first couple of days it's opened 50 times a day, because they want to show them to everybody, look at what I've got. This is a pill bottle that measures whether it is opened or not, and then that fades away, and after a couple of days you can actually start using the measurements.
Maybe what is interesting, I think you come back to that later also, Rob, is that we do actually see that in many adherence improving studies that we did, the baseline adherence of the participants was often relatively high. So we do have the impression that when you do a study to improve adherence, that the patients who consent to participate in the study are actually relatively adherent already.
Yes. Yeah, that's a big problem, and we'll come back to that a little bit later, I think. Okay, if we go to the next slide, then I want to talk a little bit about what we can then do to improve adherence, because that's in the end, what as caregivers, as healthcare providers, we want together with the patient. We want the patient to have the best benefit from medication therapy, if that is needed. And try and make sure that the medication that is agreed upon is used as it is agreed upon. And while this picture shows one way of doing that, obviously that's not the way we want to do with our patients. So in the next slide, we have a question again. Oh no, oh, I thought we had a question, but it will come. It will come. Yeah, let's do the question first. So here are a couple of options to try and improve adherence, and please go to your menti.com screen and pick one of those that you think is most effective to try and improve adherence in patients. And I understand that this is a very, very broad question, and it depends on the patient, and it depends on the medication, maybe. There's one of you that picked paying patients to take their medicines. Very interesting options. If you don't want to, you can keep it to yourself. But if the one person that said paying patient, can you tell us a little bit about that? If you want to, do you have any experience with that?
Well, honestly, Rob, that was me.
It was you. Well, do you have any experience with that?
Not in the Netherlands, but I know that there are some studies, for example, I think in the city of New York, with patients with tuberculosis. They had really big issues because you don't want to have patients with open tuberculosis in a big city. And that there are often patients who are homeless. And then they just said to them, okay, when you come to the homeless center every morning, you get a cup of coffee and a donut and $5 to take your pills. Yeah. And this is very effective.
It's been done, and it has been done in the Netherlands as well. It's been done in again, I think, homeless, or at least vulnerable patients with schizophrenia that were put on antipsychotics, and also these were paid if they took their antipsychotics, and it turned out that was a very effective way of making sure that people took their medication. It was also in the end a very cheap way, because it was much cheaper than doing all these counseling sessions, etc. Simply give them a small amount of money to take their medication, made a huge impact, gave a huge effect. Obviously, you have important issues about well, the ethical aspects of this. Are you then forcing people to take their medication in a way that you don't want to? So it's not being used, but in a study setting, it was very effective.
Well, and actually they're using it now with the COVID vaccination in some countries. I know, I think
Yeah.
in the US and some other countries also, where patients, they didn't get money, I think, but they got a beer or they got tickets or whatever to get a vaccination.
Yeah. A couple of people here in the workshop say simplifying the dosing regimen, and Francisca is also saying, well, 3D printing multiple medicines into one, which is absolutely an interesting option, and simplifying the dosing regimen has a great effect on people, and at least makes it easier to fit your medication taking into your daily activities, and we all know elderly patients taking 7 or 8 different medications multiple times a day. They almost spend the whole day taking medication because it is all not very synchronized, and could benefit enormously from these simplifications. Obviously, an important risk with putting multiple medications into a 3D printed or into some kind of a polypill is, if you then miss one of those, then you miss all the dosages at once. So then you have a bigger effect of being non-adherent. Yeah, Roland, in the USA, people got enrolled into a lottery taking the COVID vaccine, which had a great effect on vaccination. It did work. It did work. There were states where they did it. It's obviously hard to compare, but I think once they did the lottery, then it boosted vaccination numbers. Yeah. Well, this is an overview in a review of reviews we did, looking at all types of interventions that were effective, and these were here listed in different groups: technical, behavioral, educational, and other. And in the next slide, we have a list of all of these interventions. Those based on treatment simplification, so changing the dosage schedule or formulation or polypills or even 3D pills. Cognitive interventions, so educational interventions, educating, motivating patients by giving them better instructions. Behavioral interventions, so counseling, trying to build skills, to help people fit their daily regimen of medication into their daily activities by linking it to having breakfast or whatever daily things they do. More psychoaffective interventions, so social interventions, so talking about how you believe in the medication, how you feel about taking the medication, making sure there is support in taking a medication in their social relationships, etc. Feedback types of interventions, so electronically monitored adherence, so these schedules that I've shown you, and giving feedback based on those to the patient, or looking at them together with the patient, and then talking about what went well and what did not go right. Technical reminder systems, there's lots of those, so apps that give you a reminder multiple times a day to take your medication, etc. So that those are all aimed at not forgetting to take your medication. and then a feedback based on effectiveness. So blood pressure measurements at home, glucose measures that show people how their disease is going, and then making them think about taking the medication. And then there's rewards, so that's the ones that we talked about, so cash, etc., or lottery tickets. So on the next slide, I have tried to put together some possibilities of interventions, and mostly highlighting that you need to tailor your intervention to specific patients, and that should be done by a multidisciplinary team that is involved. So clinicians, prescribers, pharmacists, home care, nurses, the community, so people surrounding the patient, family, informal caregivers, and they all play a part in this, in monitoring adherence, in making sure that the information is right and understandable, tailoring regimens, reminding people about taking their medication, etc. So on the next slide, I've again listed some types of interventions, and also tried to put them into the different aspects of adherence. So is it about starting the medication? Is it about executing the dosing regimen, so not forgetting to take your medication? Is it about keeping using your medication for longer periods of time, so persistence? And is the non-adherence intentional or non-intentional? So it depends on why people are not using their medication, and how you want to intervene about it. And one of the things, for instance, in intentional non-adherence, so people not wanting to take their medication because they don't believe in it, or they don't see an effect, or they have side effects, or they are afraid of side effects, that has a lot to do with concordance. And that's something that, for instance, Camilla in the beginning also mentioned. So agreement between the prescriber and or the healthcare provider and the patient about agreeing on what the medication therapy should be, and whether the patient should take this medication, and how he or she should take it. So that it depends very much on what you want to intervene in. And it doesn't help to give a patient a reminder device or an app that says take your medication if the patient doesn't want to take the medication. Then it will not have any effect. Okay, on the next slide, it gives an overview of that, and again highlights that management of adherence, well, there's many people involved: providers, prescribers, patients, family, but it's also about institutions and even the policy. So people also have to be able to adhere and not be non-adherent because they cannot pay for their medications, for instance. So that obviously also plays a role. And in the next slide, I want to present you a couple of elderly patients that I got to know, and I visited at their home, and they were very happy, as you can see, but they were also very old. Mr. and Mrs. Kleinigris were 92 and 93 years old at this moment, and they were still living well on their own in their apartment. They had help from their children, and they had help from home care a couple of times a week, I think even daily. And they also used lots of medication. And I want to show you this because patients figure out ways of dealing with that themselves. So Mr. Kleinigris, he was very proud of his own system. He had a list of medication that he asked from the pharmacy, and it was printed for him. And then he made a schedule himself and made colored stickers, put that on the list for morning intake, afternoon intake and evening intake. And then on the next slide, you see he put those tickets himself also on the boxes, on the pill packaging. He put the colored stickers so he knew whether he should take it in the morning or in the afternoon or in the evening. And he was very proud of this system himself, and it helped them taking their medication. But you can see, well, this is something that they've figured out themselves, and there's obviously also ways in which this can go wrong. So it's important to also visit patients and talk to them and see what solutions they come up with themselves. In the next slide, Marcel, I think you will take over here and give a couple of examples of studies in which interventions were studied.
Yeah. So I will start with an intervention aimed at unintentional non-adherence. Let's start with a question. So, so when you would choose a cardiovascular drug in which you can find a clinical laboratory outcome that you can establish a clear relationship with adherence, which drug would you choose? So I hope it. So I see some different answers. I think it's probably also not like a question with one good answer. Of course, you can measure LDL levels with statins, but patients will have to be really very non-adherent before you find the problem. Thiazide diuretics, you can measure blood pressure, but it will also take some time. I'm discussing a study later on vitamin K antagonists because these have a relatively short-acting effect, and your INR will be affected very soon. Antiplatelets have a longer duration of action, at least aspirin does have. So, I was thinking about the vitamin K antagonists. These are, of course, all drugs, but we did a study with them, and we did this because there's a clear relationship between the time patients are in therapeutic range and the clinical outcome of patients. And the time in therapeutic range, you can measure this easily. So you can find a very close link between adherence and a clinically relevant outcome, because that is often a problem when you realize, for example, when we're talking about statins, the statin trials have been done often with thousands or 10,000s of patients. And then over a period of 5 years, they show that using a statin decreases the number of myocardial infarctions. But when you would have to do a similar trial to show that using your statin better or improving adherence with a statin decreases the number of myocardial infarctions, that means you probably also have to include 10,000s of patients in such a trial and have a follow-up of several years, which is, well, maybe it's possible, but you need an enormous budget. And this INR effect is much sooner, so you can measure it earlier. So what did we do? In the Netherlands, we have anticoagulation clinics, and these anticoagulation clinics, they measure the INR of patients, and we selected patients who had, for a period of half a year, a time in therapeutic range of less than 65%, because it's recommended that you are over 65%. Then the anticoagulation clinic sent a list of patients to the pharmacist in the region, and the pharmacist invited these patients and asked them, okay, do you want to take part in a clinical trial? And then patients were randomized, and what was the intervention? The intervention was that patients would receive the vitamin K antagonist in a multi-dose dispensing system. And these are the so-called, some people call Baxter rolls, medication rolls. You see them in the picture. These are plastic bags, and all medication the patient has to take on a certain dosing moment, for example, Monday morning, Monday afternoon, Monday evening, are packed in one plastic bag. And normally vitamin K antagonists are not packed in these systems because the vitamin K dosing regimens are often complicated. Like you have to take 1 tablet on day 1, it's the next day 2 tablets, then 1 tablet, 2 tablets. It varies depending on your INR. So normally they're not packed, but we made an arrangement with the anticoagulation clinic that they would send the information on the dosing immediately to the pharmacist on time, so the pharmacist had time to change these roles. And the control group that just received their vitamin K antagonist in normal boxes. And then below you see the baseline data. Well, maybe what is interesting to see is that baseline patients were already better in therapeutic range than we expected. And that had to do with the fact that we selected patients, the anticoagulation clinic selected patients on the base of an INR in the past 6 months less than 65. But by the time the patients were invited and actually took part of the clinical trial, the INR range was already improved in a number of patients. But we see that it's not good. There were many patients were between 40 and 50%, between 50 and 60%, 60 and 70%. So still a lot of patients were not good at baseline. And then we see in the intervention group a substantial number of patients, they really got to almost 100% in range. And yeah, on average, there was a significant difference in the time in therapeutic range in the intervention group compared to the control group. So this is an example of a study that shows that an intervention for intentional adherence, because these were all patients, they were elderly patients with lots of medication who really wanted to use the medication, but they just didn't succeed to do it. So a next example, and for this example, I want you to rank patients according to their adherence. So this is a different type of question. So what patients do you think are most adherent? And then like the children are now on top, of course, they will be, then adherence will be especially adherence of the parents. So can you rank them according, so what are the best adherent patients and what are the worst adherent patients, do you think? Does this work, the ranking? So I don't know whether we actually did a study like this, but it's interesting to see that you think that children are most adherent, so that parents are very adherent for the children because they really take care of the children, which might be like that. Elderly are seen as less adherent. They probably have problems with like, because they have cognitive issues. On the other hand, they are often at home.
Marcel,
yes?
I think this means that because they are almost all the same, this means that there are everybody filled in a different order.
Yeah, you're correct.
And then I think that is correct because we simply don't know.
No, yeah, okay, I agree with you, Rob. So we continue to the next example because I put this question because we did a study specifically among adolescents with asthma, and we choose this group because we know that well, children are actually more adherent. But then when children get to the age of 10, 12, at some stage, the parents will say, okay, you're responsible for your own medication now. And sometimes children, they don't want to be bothered by their parents, so they are going to do it independently. But then they really have to take responsibility, and that's difficult for adolescents because their brain is not really suited for this. And we actually see that adherence decreases a lot during adolescence. So we specifically designed a study for adolescents with asthma. And well, we had a lot of work for this, but we finally decided that we would make a smartphone application, and the smartphone application could communicate to a management system in the pharmacy. And the smartphone application contained questionnaires, which was it's called a carrot questionnaire. It is a questionnaire which measures the severity of the asthma and allergic rhinitis complaints. It also contains some movies, some educational movies and motivational movies. And also there were new movies sent to the app every month. There was a clock medication reminder, which the adolescents could use to think about the medication. They had the possibility to chat with each other, so to chat with other adolescents who were also in the study, and they could chat with the pharmacist, ask questions to the pharmacist, and sometimes the pharmacist could send, for example, a movie to the app. Well, what were the results of the study? Well, the conclusion was that once again, adherence of the children who participate in the study was relatively high at baseline. We see this in many studies. And we saw that the intervention did have effects, but especially on the adolescents who had poor adherence rates at baseline. So the adolescents who were already adherent at baseline, it didn't have an effect on those adolescents, because it's not so surprisingly, because they were already adherent. What's also interesting is to see how did they use this kind of app. They used especially the carrot questionnaire, which is a questionnaire on allergic rhinitis and asthma symptoms. They used they got adherence questions sometimes. They looked at the movies. So they were actually using the app. There was a difference. Some adolescents use it frequently, some use it only infrequently. And I want to ask you, okay, what item of the app would affect adherence most? So using what item would affect adherence most? Is that chatting with each other, so with other participants, chatting with the pharmacists, completing the questionnaire on your symptoms, and you also get a graph of how your symptoms would proceed, or watching the movies? So it's interesting. You get the idea that it's actually talking with each other, with the other participants, maybe also with the pharmacists. Well, we actually saw that female patients, female adolescents, use the app more frequently. And when we looked at the total use of the app, we did not really see that participants who used the app more frequent than others had a better effect, but especially those who used the pharmacist chat function had the most effect on adherence. So that, well, I was very happy to see this, because it suggested that pharmacists can really mean something for these adolescents. Okay, so Rob is going to take over from here with the last example, and starts with a question again.
Yeah, the final example is we've asked pharmacists to counsel patients that were started on a new chronic medication, and my question to you is, when should they counsel? What's the best moment to counsel patients? At the start, or 2 weeks after the start, or when they don't show up for a refill? So I see many people already answered, and well, it's a little bit tight for at the start of a new treatment or 2 weeks after the start. Well, we've done a study where we looked at telephone counseling by a pharmacist during the start of a therapy, and that was 2 weeks after the start of the medication. So patients came to the pharmacy with a prescription for new chronically intended therapy. They got information on that medication, and they got their first prescription. And then after 2 weeks, on the next slide, the pharmacist called by telephone the patient and did a counseling talk about, well, knowledge on the medication, on the disease, beliefs about the medication, talk about any barriers there were on starting or using the medications. Did you already start using the medication? Are you intending to start soon? If not, why not? Are you having any doubts about it? Should we talk about that, etc.? This was in a semi-structured interview, so the pharmacists were trained to do this interview. They had followed a communication course. And they were also remunerated by the healthcare insurer for each call. So they got paid for the time they took to do this call. And we compared groups of patients that were prescribed a couple of different medications and compared them to usual care. And on the next slide, you see the outcomes. So we looked at people that started ACE inhibitors, statins, biphosphonates, or antidepressants. And what you see here in the dotted lines, those are the per protocol analysis, and the solid lines is the intention to treat analysis. And you see overall a very small, not significant positive effect of the telephone counseling, but you did see positive effects in the individual groups. So especially in the ACE inhibitors, there was a big effect. In the statins also, but not significant. And in antidepressant users, no effect. So the telephone call by the pharmacist did not improve adherence with the antidepressants at all. And we don't have a very good explanation for that. It maybe has to do with, well, obviously the type of patient or the type of disease, or maybe the type of prescriber, that it may be more often a psychiatrist, but it is, well, striking that there was no effect at all. On the next slide, I want to show you a phenomenon that we've mentioned before, and that is the fact that it is very hard to do research into medication adherence improving interventions, because very often people who participate in these studies, who are willing to sign an informed consent and participate in the study, and who are willing to fill in questionnaires and have their drug intake monitored, etc., those are the ones that are already adherent, and the ones that are not adherent tend also not to participate in these studies, and also tend not to participate in any intervention action that you try as a healthcare provider. So that is a serious problem. This is an old study, but this is a striking example where they did a whole intervention to try and improve adherence in people on cardiovascular medication. Well, and the first thing that you see here is that there is no difference in the intervention group and the control group, but adherence is almost perfect in all groups. So also in the control group. So there is not a lot to improve. Because they did not select people who were non-adherent in the first place. And the same goes a little bit if you want to try and improve adherence in clinical practice. Sometimes we say, well, what you should do is ask people if they want to participate in a study on improving adherence, and all those that say yes, I want to participate, those you don't want. You want the ones that don't come up and want to participate in the study. And obviously you can't do that, but those are the ones that probably benefit most from the intervention. On the next slide, you see a big project that we are working on now. Marcel, can you go to the next slide? Which is focusing on trying to implement. So we know a lot about medication. We've been doing medication research for 20, 30 years, not we, but researchers in general. So there's been a lot of research, there's been a lot of studies into what works and what doesn't. We learn more and more, but one of the problems is that in clinical practice, we don't see a lot of improvement yet. We don't see all this research being translated into improvement of medication adherence in practice, and that's what we want to do in this project, where we go to 8 different living labs. So on the next slide, you see the first 4 living labs in the Netherlands, and this year we will start 4 more, and those living labs are first line healthcare providers, so pharmacists, general practitioners, home care nurses, other healthcare providers involved in patients, specifically trying to implement proven interventions. So we already know that the intervention works from previous studies. We are not trying to repeat those studies, but we are trying to get those interventions implemented in daily clinical practice, and that's what's happening right now. And we want those living labs to also function as a starting point for other practices around the country to pick up what we've learned there and try to implement this actually. Because on our final slide, and it's a little bit of a quote that's not always true, but in this case, I think it rings a bell. That knowledge obviously is important, but implementation is really where it's at. So if you want to change something, then you should also be able to try and get it to work in clinical practice. And I think that's one of the big next steps that we need to take in trying to improve medication adherence. I think we are at our final slide, and we are also a little bit short on time, I think. Marcel, I will give the floor back to you.
Yes, and I probably will give it back to Victoria, because I don't know what the exact plan now is. I think there should be a networking event. I don't know how this works.
Okay, thank you very much, both Marcel and Rob, for a very informative presentation. I am really sorry I wasn't able to introduce you. I had connection problems, so I had to leave Zoom and come back again. That's the problems with technology. So if it's okay with you, I will say a few words about you, and then also we will discuss some questions from our attendees, and then we will start the networking event. So although this is not the traditional way of presenting our speakers, as I said, we are really, really pleased to have 2 very experienced researchers in medication adherence and other areas. So Professor Marcel Bouby was appointed as Professor of Pharmaceutical Care at the Department of Pharmacoepidemiology and Clinical Pharmacology at Utrecht University in 2009. And his activities focus on patient adherence, medication safety, and include both observational work and evaluation of innovative pharmacy interventions for the advancement of the pharmacy profession. So Marcel is also a founding member of the European Society of Patient Adherence and Compliance, SPACOM, and he is a co-author of more than 150 papers in peer-reviewed international journals and publishes frequently both research papers and also book chapters. So thank you for your contribution, Marcel. And I'm now going to say a few words about Rob. So Rob is a professor of innovation in healthcare processes in pharmacology since March 2017, also at Utrecht University. He's also an associate professor of pharmacoepidemiology and clinical pharmacology. He has authored over 180 research publications in international peer-reviewed journal and has also served as a supervisor of over 25 doctoral candidates. And his area of research includes not only medication adherence, but also interprofessional collaboration in pharmacological care and self-sufficiency of vulnerable patients. So thank you very much both for your contribution, and I hope all our attendees have enjoyed the virtual workshop. So now we are going
Victoria?
Yes.
And Rob is also a member, a founding member of the ESPAComp.
Oh, sorry. Sorry.
So for people who are interested in adherence, this is also an interesting platform, the ESPAComp, which have a yearly conference on adherence.
I will put a link in the chat.
Yes,
so to do
please,
a little bit of
yeah. Yeah, that would be awesome if you could do that. For those of who do not know this association, it just focuses on medication adherence. So Rob is going to share the link, and there are very useful resources and also annual meetings. So please check it out. Thank you for the clarification, Marcel. So now, okay, you have the link there. Thank you very much, Rob. So we have one question from Francisca, and I think it is regarding the study you presented on, Rob, the one that was based on the new medicine service. So she's asking, mental health medicines are excluded from the new medicine service for a number of reasons, even though we know that adherence might be particularly low in this population group. Have you included mental health medicines in your study?
Yeah, I think Marcel already answered, and then I think I also answered in the presentation. Yes, we included antidepressants, and we saw no effect of the intervention, and that's a little bit what we expected, and well, it is as expected, I think, from Francisca's remark that adherence in antidepressants, but maybe even more in antipsychotics and drugs that are used in let's say bipolar disorder. We know that adherence is very low, but also that it is very difficult to to improve and to intervene. And there have been many studies trying to do so, but not very successful, I'm afraid. So yeah, I hope this answers your question.
We did some other studies in the past on antidepressants, and I remember, for example, a study which we did. We had a video, and there's a video on depression and on antidepressants, and then patients they got the video in the pharmacy when they got their prescription. And then some of the patients, they brought the medication back and they said, well, I watched the video at home and then, well, this is not what I have. I don't have a depression. I'm not going to take these medicines. Yeah. So I think this is a very sensitive area. And when you do an intervention, you really have to cooperate with psychiatrists, with doctors, and really be very careful because, well, it's often, for example, in depression, patients don't admit they are depressed yet, and then the doctor has just told them, okay, well, if you don't sleep so well, I give you something to sleep a little bit better and to improve some symptoms. They don't call depression yet and then your counseling may have the opposite effect.
very important, that collaboration, which we
Yeah.
don't always take into account with other healthcare professionals and also with patients. So, okay, Francisca is thanking you. I don't know if you discussed this from Eva regarding reimbursement systems. I think this is more a reflection rather than a question. I feel that reimbursement systems could be used more effectively to support patient adherence. In Finland, you get your medicines reimbursed better if you have a chronic disease, but nobody's controlling if you don't take your medicines. You are prevented to refill your prescriptions from the pharmacy before you have used the packets, but the reverse is not supported. So perhaps you could share some insights about reimbursement systems implemented in the Netherlands, or anything you would like to comment about reimbursement systems.
Well, maybe I can start as in the Netherlands, medicines are generally reimbursed, although patients have their own risk of like 360 euros for all their healthcare and medicine. So when you only use medicines, then it may be the first money you have to pay yourself. But generally, medicines are reimbursed, and money is seldom an issue why patients don't take their medicines. On the other hand, I think we do have a problem that, for example, pharmacists, they are paid for dispensing mostly, and they are not paid for counseling services to improve adherence. So when they would have such a service, then the patient will have to pay that himself, which is a bit strange. So that may be an issue. And other issues may be, well, the duration of dispensing. So I think this is like something which you have to do individually, because for some patients it may be a good idea to see them every month or every week to refill the medication, to motivate them. But for other patients that may be very bothersome, and they would like to have the medication for half a year. And that would improve their adherence. For example, when you're working and you have to go to the pharmacy every month to get your new medication, that's not very attractive for you. So, and the reimbursement systems are not really fit for this yet. They're often based on like, okay, you have to get a refill every month or every 3 months, or it's not really flexible for patients often, at least not in the Netherlands, and probably many countries, I think.
Mm-hmm.
I agree about reimbursement. Direct reimbursement in most cases is not a big issue for adherence, at least in the Netherlands. But it is in some vulnerable patients, and again, for instance, people with schizophrenia, sometimes homeless, sometimes out of work, having insurance problems or administrative problems, and there you can see that this is an issue. And then even a small, let's say, reimbursement fee or something like that they have to pay can cause them not to take their medication. So it does depend on the patient or the people involved. Yeah.
Thank you very much for your answers. And we have
maybe somebody has can maybe from some other countries we have some discussion on, because we know that, for example, in the US it may have a big problem, because like 20-25% of the patients is uninsured, so they will have very big problems.
Would anybody like to comment on this issue? Perhaps share how it works in your home countries? Nobody? Okay. You can.
Well, I can have a comment on this as I raised the question.
Yes. Yes.
This is Eva speaking.
Yeah.
So in this country, we use a lot of money to give this specific reimbursement for these chronic patients, but then we do not follow at all what happens really. And I think this is a little bit a unhappy situation, because it's a very a system which tries to find out the mistakes, but not give any incentive to do the things right. And as it's a big money from the society's point of view, I think it should be used also to help us, especially with the non-communicable diseases where the non-adherence is known to be a huge problem. And from the pharmacy point of view, we see that these people, are they visiting the pharmacy, or are they taking their medicines, or are they not taking them? And independent on this data, they will be given the same status that they still want to have the better reimbursement, which for me is a little bit odd. So once you are in the system, you can do whatever you want to, and you get your reimbursement. But if you are out, it's very difficult to come in. So you can, the system is not working in a best way to support people in their adherence, or even in their knowledge about how to use the medications right, which is also a very important thing, because we know from the diabetes patients, for example, that the longer they use the medications, the more we expect that they know how to use them, which is not true.
I think that's a very important point, and definitely an area in which we have a major role to play. For example, I will comment on Australia. There are different pharmacy services which are funded under different schemes. So the government is funding, similar to a medicines use review service, one for patients with type 2 diabetes, and another one for patients who are using 5 or more medicines, and that's targeted at patients. Well, the overall objective is to try to increase medication adherence. And then there are other private services which are aiming at improving patient adherence, but during the dispensing of medicines. So for some specific medications, the dispensing system can have a pop-up window letting the pharmacy know that that patient is not being adherent, and that triggers a conversation with the patient regarding the use of medicines. Perhaps, Camila, can you say something about Denmark?
Sorry, I just needed to find the right window.
Yes.
Yeah, I think it's actually kind of similar to what you just told. We have two kind of pharmacy services in Denmark that is government paid. So every time that we provide them, similar to the new medicine service, or then we have a compliance service as well. So if we spot a patient that we think are non-compliant, we can offer a compliant conversation with the pharmacist, and then it's for free for the patient, but the pharmacy is paid by the government for providing this service. It's just a comment from earlier on that the only thing that we are, or the primary thing that we are earning money at the pharmacy are by selling medications. That is not the picture in Denmark. Actually, it's kind of a bad business selling prescribing medication in Denmark, because it's restricted by the government.
Thank you very much for your insight, Camila, and for sharing the experience in Denmark. Any more questions from our audience? We also had a very interesting reflection from Eva. I always find interesting discussions with one of my patients who is using those dispensed medicines. he does not always take his medicines, and he spares all the packages he hasn't taken, and he shows them to me and tells that he's still alive and doing well. I try to tell him that he could do even much better if he could take all the pills. We have interesting physiological discussions about adherence. It's always good to know about interaction with real patients, Eva. Yeah, that's definitely difficult to address if the patient says that he's doing well, even if he's skipping doses and if he's skipping medicines. So anything you would like to comment, Marcel or Rob, on that? Patients who are feeling better, they feel that they are doing well, so they don't feel the need of probably taking the medicines.
Well, I think the takeaway message here is, well, this is an excellent starting point for a conversation, and it's good to have a patient that is open about discussing this and sharing whether he or she is taking the medication, how they feel about it. So I think this is excellent, and the goal is not to force a patient to take every medication that is, but to have this conversation and come to an agreement and to concordance about taking the medication. Obviously, if there is something there in the way that people are taking the medication that is dangerous to them, well, then something should be done about that. And but if this is the case, I think these conversations are the best way you should go forward to.
Yes. In addition, I think it's an opening for this discussion, and
Exactly.
especially from why would you take your medicines and why wouldn't you take them? So what would motivate you to take them and what would not motivate you? So for example, patients may say, okay, I don't want to have a stroke. This is the worst thing I could imagine. And then you can explain them, okay, maybe this will help you for not having a stroke. But another patient may say, I just don't want to take a lot of medicines, because when I take a lot of medicines and I'm reminded all the time of the fact that I'm an old person who is sick and I just don't want it. I want to be, I don't mind when I live 2 months shorter, my life is completed and I don't want to take the medicine. So this is a discussion you have to have with the patient, I think. But it will be different for every patient.
I think it's also very important to use evidence-based theoretical models for changing patient behavior, and some of those take into account perceived severity, susceptibility of the disease, and you can definitely cover future implications if medicines are not taken as prescribed. So yeah, very interesting discussion point, Eva. And as I said, always good to know about real conversations with real patients. Okay.
To measure this, we use this in, but it's more like in a medication review study. And we are using this also now. We use this is called co-attainment scaling. And then you try to discuss with the patient, okay, what is important for you? And for some patients, it can be, okay, I just want to take less pills, less medication. For another patient, then I want to prevent a stroke, or I don't want to have side effects. So you're discussing with the patient, what is most important for you? And then you can say, okay, what fits most with this? And sometimes you can then, the decision can be, okay, then we just are going to de-prescribe and we're going to stop medication. For another patient, it could be, okay, then we have to add more drugs because you don't want to get osteoporosis. So we need to have you on vitamin D and on bisphosphonates and on calcium. So you will get more pills.
Yes, yeah, that's very relevant as well. Yeah. I always find, I would like to mention that we did 2 evaluation and implementation studies with pharmacists in Spain. So one of them was, we were evaluating and then implementing comprehensive medication reviews. So it was a really long service that involved collaboration with GPs, the service provision was quite long because it involved different phases. And then after that study, we did another one also evaluating and implementing an adherence service. And in that one, the intervention was it was a bit more complex in the sense that it involved the application of theoretical models for changing patient behavior. And I have to say that pharmacists, even though the service was shorter and we thought it was more straightforward, pharmacists really struggled with the provision of the intervention because they were not used to apply those complex or those frameworks which they were not originally trained to deliver when they did the undergrad or postgrad. So it was a very interesting finding because we thought, you know, the comprehensive medication review, because it is more time consuming, lengthy, we thought they would struggle more with that one. But yeah, very, very interesting, the training of pharmacists. Okay, thank you very much. So other questions? No? Okay, so now what we are going to do, we don't have much time for networking in the room, and I can see most people have their cameras off. So the objective now is to put people with common research interest in touch. So we had two options: either do it here, but considering the number of people and that we cannot put you in breakout rooms, I'm going to suggest that you go into our Facebook group. So I'm hoping that everybody is a member. If you are not a member, please let me know so we can accept you. And I'm just going to post a comment about medication adherence research. So the idea is that you reply to that post, just letting us know what is your research interest and further input that you would like to have from the SIG or support. So if you could let us know in the Facebook group after my post, that would be amazing. So please feel free to share your area of expertise, research interest, so we can put together people with the same interest. So I'm just going to post it now. So the post, in case you cannot see it yet, is: are you interested in medication adherence research? Are you willing to interact with other FIP researchers with similar research interests? Please share your area of expertise and interest below. So please feel free to comment. Okay, thank you, Rob. Thank you very much for your input and for your expertise, and we hope to see you in future events. Thank you very much.
Thank you very much. Thank you. Bye-bye, everybody. Bye.
Bye.